Don't mind, please. Have your seat, please. Bene. Good morning, everybody. We are going to start if someone else wants to take their own seat. I hope you enjoyed yesterday the very interesting panels we had. We talked about prevention and innovation to foster healthy and active aging through a lifelong prevention. And today, we are going to delve into this issue and to understand why yesterday we kept on saying prevention is an investment. We are talking about money this morning because every time we ask for more prevention, there are some issues about too much costs and so on. But today we will see with evidence, scientific evidence, how prevention is really worthy. And the quote of prevention funding should be increased in our countries. So let's start with the first panel that will be about investing exactly in lifelong prevention. First of all, I call Graziano Onder on the stage. Please take a seat beside me. Michele Cecchini, here. Chris Brown. Raffaella Basile. Masato Izuzzu. And Daniela Boccadoro Ameri. So, we can start. Graziano Onder is a medical doctor and full professor at the Department of Geriatrics at the Università Cattolica del Sacro Cuore in Rome, and also scientific coordinator of the National Institute of Health, Italian National Institute of Health. So, Professor Onder, based on your professional expertise, can you help us frame the major epidemiological features of aging and how is this impacting on our societies and healthcare systems?
Yes, sure. Thanks a lot for the invitation and for the question. So we know that life expectancy is progressively increasing. In the G7 countries, life expectancy reached 81 years, mean life expectancy, ranging from about 78 years in the US to 84 in Japan. We had a slight decline during the COVID-19 pandemic, but nowadays life expectancy is increasing again. What are the consequences of these increments in life expectancy? First of all, NCDs, non-communicable diseases. We have talked a lot yesterday about risk factors, but nobody said that the strongest risk factor for non-communicable diseases is age. Therefore, as people and population age, we will be facing a real epidemic of NCDs. And also another aspect related to this is multimorbidity, because we are seeing people with not a single non-communicable disease, but multiple non-communicable diseases. 2/3 of the older population suffers from multimorbidity. And as you can understand, this really challenges our healthcare systems that are very much focused on the so-called single disease-oriented model. We treat disease by disease rather than providing integrated care. Second epidemiological consequence relates to disability and functional decline. There's a substantial gap between overall life expectancy and healthy life expectancy, about 8 years. So each of us will be faced about 8 years of disability in our life. Clearly, more NCDs, more disability mean higher use of healthcare services, particularly long-term care services. And last factor to be considered epidemiologically is the increment of the population at the end of life. This is rarely considered, but we are now facing a huge population, very advanced in age, with many NCDs, complex conditions that is difficult to treat. And this really raises ethical challenges and dilemmas. Please consider only in Italy we have 800,000 people 90 or older. So this will be clearly another challenge for the future. So how does this epidemiological situation impact on the society? First of all, that's the reason why we are here, is increment in healthcare costs, for sure, specifically long-term care, LSC. Second, need of an increment in healthcare workforce, because that's the other important area to be considered to face all this level of NCDs, disability, and so on. Third aspect relates to social support. We need more social support from family, from community services for older people. And public health policies, probably a need or more public health policies oriented to older people and to prevention of NCDs and disability. And last but not least, as I said earlier, legal and ethical issues. I mean, that should really be necessary to address, to face the challenge of end of life in the older population. So this is more or less the frame which many of our countries are seeing in these days.
Okay. You said that we didn't mention age as a risk factor because that's not a preventable factor, but we as yesterday was said, we want to age. We don't want to die early, but we want to age healthy. And so let me introduce Dr. Michele Cecchini, specialized in public health, and has a master's degrees in health policy, planning and financing from the London School of Economics and the London School of Hygiene and Tropical Medicine, and a PhD from Imperial College London. He's responsible for the OECD program of work on public health, including work on preventing unhealthy lifestyles and assessing and providing advice on reforms to improve public health systems. Dr. Cecchini, yesterday Professor Scarpetta mentioned some data on the impact of aging on health and productivity. Can you tell us more about the cost of the different determinants, risk factors behind this burden?
Thanks for the introduction. Good morning, everyone. I would add one important point to the introduction. I'm also native from Genova, born and raised here, so I play home today, and I'm of course very happy of this.
I hadn't been told about this.
The work that OECD does, as you introduced at the beginning of the session, is to look at the economic dimension of major threats, challenges, but also opportunities for our member countries, of course, including the G7 member countries. If we look at what happens across OECD countries, we see that there are more 3 million deaths every year that we could avoid. These are deaths that can be considered as preventable. And 2/3 of these deaths, meaning nearly 2 million deaths per year, are deaths that we can avoid with better prevention, healthier lifestyle, avoiding unhealthy lifestyle and products. So, as Director Scarpetta pointed out yesterday, this is first and foremost a very big public health issue, but it's also an economic problem because these diseases have also very practical economic implications also in the pockets of each of us. For example, looking at the workforce, we see that persons that have chronic diseases are less likely to find a job. In some cases, even if they have a risk factor, are less likely to find a job. Overweight women, for example, are discriminated against women that have the same level of education in terms of being employed. If we look at the chronic diseases, persons with diabetes are 10% more likely to be unemployed compared to persons that do not have a disease. If they have a job, they are more likely to miss days of work, to be on sick leave. Persons with cancer are 40% more likely to be out of the job, of the work, in the first year after the diagnosis. Finally, they are more likely to retire early. If they are sick, they are likely to ask to retire, and having a chronic disease increasing by 20% the probability of dying. And this has cost for the healthcare system. Across OECD countries, around 9% of healthcare expenditure is to treat, for example, the consequence of overweight. Overweight, unhealthy diet, lack of physical activity together are the first cause of burden across countries of the G7, but also OECD countries. The consequences on the workforce that I mentioned impact the gross domestic product of countries, the economy of countries. We calculated that the consequences of NCDs, those related to overweight, unhealthy diet, and lack of physical activity, decreases the GDP of OECD countries by nearly 3.5%. We are talking about a massive amount of money. I mean, when we do, for example, the end of the year review of the budget in countries, we are talking about amount of money which is much smaller compared to more than 3% of the budget. And this is also impact, as I said, each person, whether this person has chronic disease linked to overweight or not. We calculated, for example, that due to overweight, each citizen across G7 countries pays a tax which is equal to around 620 euros. $620 equivalent to 570 euros. It's quite a bit of money that people have to pay to cover for extra cost of chronic disease linked to obesity. And if we look at the new generation, I know that today the main focus is on active aging, but youngsters of today will be the elderly of tomorrow, and we need to put them in the condition to flourish and to support our economies. We calculated that, for example, children that are overweight have an 11% lower probability of performing well at school. Lower performance at school today means a lower opportunity to get a good job tomorrow and then to have, for example, a good pension when they retire. Of course, capturing these costs is important, but even more important is to take action. And I'm sure that in the next round of questions, we'll also have the opportunity to talk about how we can tackle these major disorders.
Thank you, Dr. Cecchini. You needn't apologizing about talking about children, because we are considering the lifelong prevention that, as we said yesterday, starts even before birth. So it's very important. Now we have Chris Brown. Chris Brown is head of the WHO European Office for Investment for Health and Development in Venice, Italy. In the context of European recovery and resilience priorities, she's also leading the WHO Europe Universal Wellbeing Economy Initiative, which is convening central banks, health, finance, and economic sectors around new economic policies and approaches to investing in well-being and health equity. Dr. Brown, how can we unlock the benefits of healthy aging across the life course through reducing inequalities? It is a big issue.
Yeah, thank you very much, and thank you for the opportunity to be here today and to participate in this panel. I mean, yesterday and today we've heard colleagues talk about the fact that we have 200 million people in Europe over the age of 65. That's 1 in every 5. The last 20 years, we've seen an increase in those living in poor health, but there's an inequities in that. So men are living on average 8.3 years in poor health in their life, but for women, that's 11 years. So that's a decade of loss of human capital between men and women. And that's not the only way that health in later life is unequal. For example, the bottom 20% in all of our countries of income and education groups are twice as likely to report poor health and be living with limiting illness that affects their ability to participate in life. 1 in 7 of over 65s today are living in poverty. And so what that means is there's a huge insecurity in accessing food, medicines, care, green spaces, decent housing. And so when we talk about prevention, and we talk about the need for exercise and diet, we need to remember that for some people, this is not accessible and affordable. However, there is a good news to this. Our work in 2019 and reviewed again last year in 2023 says that if we are able to reduce inequalities just by 50%, The return on investment in terms of GDP in European countries would be anything between 0.4 to 5%. And if you're interested to know what that would be in Italy, that would be 4.2% improvement in GDP just from reducing inequalities. Our work is also recognizing that it's not just the health sector that's interested, but it's also other sectors. So there's benefits of reducing inequalities for the more cohesive and trusting societies, which we know is a big problem today. Ability of resilience, so a society to bounce back after crises. So when we look at that, there's multiple benefits. So what are the answers? I'd like to pick up very quickly 3 different ways across the life course that we can achieve or contribute to that reduction in inequities. One is by giving every child a good start in life, and we have to recognize that many children today are experiencing adverse childhood experiences. That's abuse, poverty, living in impoverished environments, witnessing violence. 16% of adults experience 4 or more of those conditions. This increases their risk of mental health, cardiovascular disease problems in adult life, which continues to later life. So what we know works is parenting programs, parenting support, high-quality early years training, including health and social skills, subsidies for housing and food, and reducing tax and making healthy food and homes available. If we did that, the return on investment would be a reduction in the number of adults, including older people, with mental health by 44%. It also return an annual GDP return of 3.6% of GDP in North America and 3.4% in Europe. My colleagues have talked about young people, so I'm actually going to talk about maybe working years. If we were to reduce limiting illness, that's illness that participates economic, social, and cultural activity, that would, which currently is 3 times higher limiting illness in the bottom 20% of the population. If we were to reduce that, we would get 300,000 lives in 4 years in a country of 80 million improved. So for politicians, when they say it's difficult to reduce inequalities, by investing 0.1% of our GDP in social protection policies, health and social care, decent living conditions, we can achieve these gains. This has also been done on a whole-scale basis in many countries, and we see that not only are the gains for reducing inequalities, but generally in the population we get higher social cohesion, better inward investment, so there are gains for the economy and society. In terms of what WHO is doing about this, we are convening central banks, finance and economy sectors around investing in this, developing new modelling tools for central banks to put this in their regular forecasting. And we are convening leaders, world leaders at the side events of the United Nations General Assembly around how we can reimagine an economy with health and prosperity and well-being at the centre. So thank you very much.
Thank you. You're saying that investing in health in all policies is a win-win approach, I guess. So thank you very much for this perspective. Now, Raffaella Basile is the Director of Office in the Direction of Economic and Financial Analysis and Research of the Italian Ministry of Economics and Finances. She analyzes the sustainability of public debt, potential output growth, pension, and healthcare costs in the short, medium, and long term. Dr. Basile, you lead an office that analyzes the costs associated to pension and healthcare for the elderly. This is a very hot issue. Can you please provide us with some insights on the work that you are doing to assess the risk factors connected to aging? Maybe it's just to switch it up. Okay?
Good morning, and thanks for the invitation. At the Treasury Department, we analyze major risks on debt sustainability deriving from the demographic transition within the European Economic Governance Framework, and in particular looking at the newly introduced reform of the Stability and Growth Pact, which is a set of rules aimed at promoting sound public finances and the coordination of fiscal policies across member states. The new framework is based on a medium-term approach that consider, let's say, next 15, 10, 20 years. And it's based on a new methodology that is called the debt sustainability analysis. This methodology uses a set of assumptions on macroeconomic and financial variables, such as economic growth, interest rate, inflation, and notably projection on age-related costs. These costs include not only healthcare spending, but also pension, which actually is the main drivers of the projected increase in age-related expenditure in countries, but also long-term care and education expenditure. So the new framework clearly points out that budget policy must deal with increasing aging costs in the medium term. Indeed, in the absence of any corrective fiscal measures, the increase in age-related expenses will bring to a deterioration of primary balance of the general government sector and, in turn, to an increasing debt to GDP ratio, which would be unsustainable. The second channel by which population aging affects the sustainability of public finance is, of course, economic growth. And these issues has been largely stressed also yesterday and also today, because the first consequence is the decline in the workforce. Let me recall that according to the latest projection of the aging report of the European Commission, the workforce, which is the number of active people aged between 20 and 74 years that provide the labor in the labor market, is projected to decrease by 12% by 2070. In the case of Italy, by more than 8% in the same period. But population aging also impact on labor productivity. Indeed, business dynamism and entrepreneurship could be eroded by aging. Let me say that the evidence is, however, mixed. In the sense that the evidence that individual productivity is falling with aging is mixed and could be mitigated by well-targeted strategies, among which, for example, lifelong prevention strategies that could avoid the decline in capabilities of older workers. Thanks.
Thank you very much. The point of aging societies is not only the elderly, but also the lack of young people. And the same issue is between Italy and Japan, who are very similar on this. Dr. Masato Izutsu is Senior Coordinator for Global Health and the Japanese Ministry of Health, Labor and Welfare. Italy and Japan, as I said, are so far but so near in this point. Japan has held the G7 presidency in 2023, just before us, and one of its main health focuses has been on universal health coverage. And is it somehow related to invest and promote healthy and active aging?
Thank you, Roberta, for the invitation to such a great panel. And it took 18 hours from Japan to Italy, but it's rewarding to be here. And firstly, as Roberta mentioned, Italy and Japan has a lot in common in terms of the aging. So let's say the percentage of the population aged over 65 in Japan is about 30%. And then the figure in Italy is about 23%, if I remember correctly. And Japan is the second highest country according to the World Bank data, and Italy is the third highest country. And then in terms of the question whether the UHC is relevant to the investing healthy and active aging, the answer is surely yes. And I think many of you have already known the concept of universal health coverage, but let me recap the concept. The concept of universal health coverage is all people can access quality healthcare service without financial hardship. And in this context, healthcare service includes not only treatment, rehabilitation, palliative care, but also promotion and prevention. And Japan has achieved universal coverage in 1961, and it said that no single universal health coverage system can fit all countries. So even among the G7 countries, the universal health coverage system is different. And what makes Japan's universal health coverage system unique is we do not apply gatekeeper system or referral system. So it means everyone can access any clinics, any hospitals without any limitations. And then this help establish and increase the number of healthcare facilities across the country in Japan. And then this results in the 80% of healthcare facility is managed by private sectors in Japan. And then as for the healthy and the active aging, it is important to work on the extending healthy life expectancy. And the Ministry of Health has launched the National Health Promotion Program. It's called Health Japan 21st. This initiative includes full sets of the promotion menus, such as behavioral change, nutrition, physical activity, sleep, alcohol consumption, smoking, enhancing quality of social environment, and mental health. And then this menu is provided for general population through their life course. And then in order to implement this program, healthcare professionals play a critical role to make this initiative successful. And then, as I said, thanks to the Japan's unique universal health coverage system, healthcare professionals are well distributed across the country so that general population can access healthcare professionals very easily. In conclusion, I would say UHC is a foundation to implement healthy and active aging in Japan. Thank you.
Thank you very much, Dr. Rizuzzo. Universal health coverage is a fundamental right that in Italy is guaranteed by the national health system that we have to defend. And in any case, it's so important, especially related to this issue. So now we have Daniela Boccadoro Meri, who is a journalist and media relations and institutional relations expert. She's the creator and president of the Silver Economy Forum and founder of the website Altra Età. Dr. Boccadoro Meri, we've listened carefully to all the panelists so far discussing on the burden of aging. The question is aging just a cost for the society, or can be a contribution, an opportunity for our economies?
First of all, I'd like to thank the organization to be here. I'm very glad. I listened a lot of things, very interesting. Thank you. Aging is often seen as a cost to society, mainly because of either healthcare costs, pension, and social services. But we often forget the positive sides and the contribution that older people make to our economy and society. In the past, aging was seen as an abnormal or problematic phase of life. Today, we have a new phase of thinking, which we call active aging. Aging now includes many factors: biological, cultural, social, and economical. Today's older people are more involved and in everyday activities. They possess more resources to feel fulfilled and are more agile, quicker in reasoning and processing information. This success can be attributed to healthier lifestyles compared to the past. People are not only living longer, but are also living better. The challenge of the contemporary world will be aging healthily. Seniors are a valuable part of the population with significant buying power and spending capacity, already comprising about 24% of the total population today. This cannot be ignored. Their consumption is both responsible and loyal. According to 2023 Istat report, in Italy, this sector makes up between 17.6% and 19.7% of the GDP, which is over 300 million euros. It is estimated that by 2030, this will be about 25%. In the tourism sector, seniors are an important and valuable target, supporting the sustainability and future of the tourism industry, in particular of season tourism. Season tourism for tourism quality, high-level tourism, tourism for hotel, big hotel and very expensive hotel. For young people is very, very difficult. If you consider that Italian seniors spend roughly 5 billion euros in holidays, it's a significant figure compared to the younger demographic. Grandparents also play a crucial role in supporting families economically and educationally. According to a Coldiretti survey, in 40% of Italian families, grandparents help balance the family budget. Many seniors continue to work well beyond retirement age, bringing a wealth of experience, knowledge, and stability to the workforce. Their participation not only directly contributes to economic productivity, but also supports mentoring and the development of younger generation. This is very important. The silver economy is gradually shifting into a new concept of longevity economy, which concerns not only about demographic change, but also the extension of life. The concept of active aging is widely talked about during the Silver Economy Forum, the national event for people over 60, organized every year in Genoa by American Communication. Since 2018, the forum has been discussing these issues, finding solutions, and providing the silver economy sector. We discuss key topics such as prevention, well-being, and nutrition, digital health, economic sustainability, tourism and leisure, new housing, solution, and so on. The goal is to promote a new lifestyle after 60, different from the past, by bringing together key public and private stakeholders and actively involving senior citizens.
Thank you very much. This is another part of the story, another perspective, unfortunately not applicable to all the elderly, and also make some point about the future, because of course these young adults that can rely on this elder, which older people will be. Who will they be? So this is another perspective. Now I want to ask Professor Ronder, is also a scientific director of the National Institute of Health. So you could provide us with an idea of how the research institutes can give evidence on which we can base the intervention for healthy aging, and especially what the Italian National Institute is doing for this purpose.
Yeah, so thank you very much. As you said, I'm here representing ISS, the Italian National Institute of Health, which represents the technical and scientific body to support of the Italian NHS, of the Italian National Health System. ISS provides constantly evidence to support and drive NHS choices, and as I see it, its activity cannot be seen as disjointed or separated from the activities of the Ministry of Health and from the priorities of our NHS. So how do I see the impact that ISS and other national institutes of health may have on policies and on supporting Ministry of Health and NHS? Well, first of all, I think what is really key is to provide evidence, generate data, identify high-risk population. So evidence based on which the decisions, so policymakers, Ministry of Health, can build their politics. It's not closely related to healthy aging, but just consider what ISS and other national institutes of health have done in the context of the COVID-19 pandemic, where we daily provided data on the epidemic to the Ministry of Health and the government based on which our policies were built. We can do exactly the same thing for NCDs or healthy life prevention. Second aspect relates to the definition of guidelines, good practices, recommendations to drive on one side clinicians to act correctly, and on the other side to support the organization of care in the NHS. This may be extremely important, and we have a department of ISS that specifically focuses on the production of guidelines and in supporting scientific societies in defining good practices. Very similarly to what has been done by NICE in the UK, for example. So provide guidelines and recommendations. Third relevant aspect relates, in my opinion, to training and education. Education not only at the patient level, health literacy and patients empowerment, but also on a health professional level that is absolutely key to drive the change and to promote prevention. We have built in the past a platform jointly with WHO that is called Laboratorium, that is available to host training courses for health professionals on different kind of topics. Fourth relevant aspect relates to monitoring and surveillance. Any kind of intervention at the NHS level should be monitored and its effect assessed over time. And it's particularly important to underline that ISS is hosting different surveillance systems and platforms to monitor the quality of life and health of the population starting from childhood, even earlier, pregnancy, to very old age. So this is really another activity that may be extremely important. I'm almost there. Technology. Technology is another issue. Yesterday we talked a lot about artificial intelligence and the importance of artificial intelligence. Absolutely key for the NHS in the future, but somebody should have the knowledge to use this technology. And I think this is what, and this and other technologies. And this is what ISS and other national institutes of health can do. At ISS, we are planning to build a new department specifically focused on artificial intelligence to really support the NHS and other governance bodies in driving this change and putting our knowledge available for NHS to this change. Last but not least, collaborative research, because what we do nationally can add further strength if done internationally and cross-sectionally across different countries. Here I want to mention the joint action Jakarta, that is a big European effort focused on cardiovascular disease and diabetes, funded by the European Union. So I saw Dr. Marcella earlier, but I thank him for supporting such a big action. That is led by ISS, and it has absolutely the main aim of identifying good practices and bringing good practices in place in different European countries by implementing 140 pilots activities in 21 EU member states, involving more than 70 institutions in Europe. So collaborative research and collaborative networks which involve National Institute of Health can really help to support and to give further strength to what has been done nationally. And I want to close just saying what I said at the beginning. All these efforts should be should be available for our NHS. Our NHS and Ministries of Health are those that set the priorities, and we as ISS, as National Institute of Health, work on these priorities. So nothing will be possible without a strong interaction between Ministries of Health, NHS, and national health bodies. Thank you very much.
Thank you very much, Dr. Onder. I appreciate very much these evidence-based policies and the cooperation among different agencies to improve health all over Europe. So I'm asking Dr. Cecchini how the OECD analysis have supported policies towards aging on this point.
Thanks. You're perfectly right, and I want to start from one of the latest statements of the colleague. Implementing best practices is really key in the way to move forward in the context of an aging population, growing risk factors linked to aging, but also to unhealthy lifestyles. At the OECD, with the work of member countries, we have co-developed criteria to select best practices. What is a best practice in public health? We concluded that there are six characteristics that a public health intervention needs to achieve to be ranked as a best practice. And many of the interventions that are, for example, part of Jakarta, but other action carried out across European Union member states, but more in general across OECD countries, can be defined best practice. But getting back to these six criteria, the first one, a best practice needs to improve population health. That's the first and foremost objective of a best practice. Second, it should give a good return on investment. Implementing public health policies as cost, and we want to use our money wisely at the maximum of what they can provide for the amount that we spend. Number three, the best practice should be affordable. There are certain interventions that they increase population health. They are also cost-effective, but they are not necessarily affordable for all the countries. Perhaps for the G7 countries, being among the wealthiest countries in the world, but moving to other settings, they may not be affordable. Number four, and now I link instead of what the colleague from WHO was saying before, they should decrease inequalities. It's very important that with our intervention, we aim to decrease inequalities. Number five, they should be feasible, implementable. There are certain interventions that in an abstract world could be potentially achieve all the objectives that I said until so far, but then in our practical world, well, perhaps they are not feasible to implement. Number six, it could be possible to scale them up and transfer. OECD, WHO, all the international organizations do a lot of work to help countries learn one from the other. There are certain things that may work super well in a context. It may be more difficult to implement them in other contexts, or perhaps they need to be tweaked a little bit, so be to adapted and transferred to the other context. And this is also very, very important. Now, if we look at the analysis we carried out, I think that today I would like to share with you three overarching messages. The first one, when it comes to public health and promoting an active and a healthy aging, one of the most important things is not to implement single intervention, but to implement packages of intervention. Packages of intervention have a greater return on investment and have a higher ability to change people's lifestyle and promote their life. Let's take, for example, workplace-based intervention. This is an intervention to promote healthier lifestyle in the context of the workplace where people work. These interventions are generally effective at the population level, and they are generally also affordable, particularly for governments, because a good part of the resources are invested by the employers. However, if we look at the share of the population, particularly in countries such as Italy, that work for employers that can afford and can roll out this type of intervention, we see that they cover a small share of the population, because there is a large share of the population that is outside the active workforce, and because, for example, small and medium enterprises that are those most prevalent in countries such as Italy may not find this type of intervention affordable. So we need to complement this type of intervention with others. Packages can also build synergies across different interventions. Mass media campaigns, for example, to promote healthier lifestyle, or, for example, to get vaccinated, produce a higher impact if they are coupled, if they go hand in hand with intervention delivered by primary care service that reinforce further the messages. People, in general, and rightly, trust their general practitioner. The general practitioner are very powerful in delivering public health messages. Second point that I would like to make is that ministries of health need to create alliances with other ministries. If we think, for example, an intervention for tobacco, there is the WHO Empower package, which is the globally recognized way forward. Intervening with this intervention, at least half of these interventions are outside the direct control in terms of implementation of ministries of health. There must be a collaboration between Minister of Health and other ministries for the enforcement of, for example, of regulation, price policies, and so on. Last point, and I stop here then, is that, of course, to create these alliances, the Minister of Health needs to sell better, to make the case with other ministries to implement public health policies. Some of the key figures that were shared by the colleagues from the Silver Economy Forum, the Ministry of Japan, show how healthy aged population may, for example, contribute to the economy. And I think we can do better in making the case that other ministries should be interested almost as much as us in active and healthy aging. Thanks.
Thank you very much for stressing again the importance of rules. So these rules for best practices, I think, are very useful, not to focus on one good idea, but to understand what can be really effective, and on the need of cooperation. Intersectorial cooperation is absolutely needed. And Dr. Brown, 1 out of every 5 people in G7 and EU countries is already over 65. How can we invest in the health and well-being of these 200 million people who are already, let's say, elderly, to prolong independence, quality of life, and the resilience of our social and economic systems?
Thank you. I mean, just listening to the colleagues, I mean, it's very obvious we don't have any option. We have to invest because this is critical for fiscal stability, even if we just look at stabilizing healthcare costs, reducing long-term costs, but also in terms of having economies that can bounce back and grow. So I'm not going to talk so much about the data. I think the colleagues meant by the silver economy are great, just to highlight here that actually healthy older people right now in all of our countries contribute 1.4% to our GDP in the social, volunteering, employment and caring activities. And if we were to increase by just 0.1%, which is affordable for all countries, to keep people healthy when they're 65 plus, this would actually boost the spending of older people by 9%. So we see that there's economic, social and health reasons. I'd like to maybe also pick up on the point that my colleague here has made, is that we won't get these returns on investment without using a basket of policies that are mutually reinforcing. So I'd like to talk about three. Age-friendly communities in terms of social and physical infrastructure. 2, how we reduce loneliness and isolation. And 3, how we deal with falls and keeping people independent. So if I look at the first one, it's really how can we design societies today for mobility, access, safety and participation? Well, we know that one of the big issues is the kind of environments that people live in. So is there street lighting? Is there free green space? But it's also about their homes. Today we have many older people living in damp, unsafe houses. It's a risk for falling, but it's a risk for respiratory diseases. So basically, policies that focus on energy efficiency homes, we know release a 4-fold return on investment, and this is in UK and USA. We get a better respiratory health, we get reduced GP attendance, and we get reduced hospital admissions. Secondly, other ways of infrastructure is to harness technology to keep people healthy and active. Digital innovations, particularly for older people living in remote and isolated areas, are super important. Sweden, UK, Germany, many of the G7 countries are using telemedicine tools to support consultation, diagnosis, self-monitoring and management. And in Sweden, the cottage hospital system is doing that. We're seeing big gains. Empowered patients, more confident in self-care, early detection of problems and therefore less costly interventions later, and older people feel independent and valued. So they're just 2 examples. I'd like to maybe look at now preventing loneliness and isolation. 1 out of every 3 older person experiences loneliness. 1 out of 4 social isolation. And both of these are linked to the same kind of mortality risks similar to smoking, obesity and physical activity. So this isn't just an added extra. We need to put this at the center of all our interventions. A couple of examples here. The Caring Neighbourhoods Initiative in Belgium is actually bringing public-private volunteers together to keep people active and healthy in the home, working with local planners, but also with service providers to design environments where people can interact, reduce inequities, and support mobility. We know, we haven't heard much today about men. We know that women live longer in poorer health, but we know that men die earlier. And part of the reason for that is seeking healthcare late, masculinities that say it's not okay to talk about our feeling, but we know mental health and social isolation are big. Initiative called the Men's Health Shed, which brings men together in the local communities where they are to talk about solving problems, to learn new skills, to get access to information, is releasing a 77% reported improvement in literacy skills, 90% improvement in social skills, 91% of the men report feeling improved well-being, and 67% improved their digital literacy. Finally, we're talking here about artificial intelligence and technology. Well, actually, assistive technologies for older people are super helpful. And just an investment in 4 products, hearing aids, prosthesis, eyeglasses, and wheelchairs, return a 9.1 return on investment. So that's for every dollar or every euro, 9 returned. And France actually is doing that and is making hearing aids freely available. This keeps people able to interact with their peers, their partners, their family, and their care. I just want to say one final thing there around that. Falls prevention is huge. The first fall can change an older person's life and health trajectory. So we know that hospital admissions, 2,000 every year in the UK, 4 million bed days, 2 billion healthcare costs of falls that are preventable. But we know that if we do home exercises, home improvements deliver a 7-fold return on that investment and a 2-fold return from group exercises, keeping people healthy in the community, reducing healthcare costs. What's WHO doing about this? We have a global network of age-friendly cities and communities. All the G7 countries are part of that. 12 networks nationwide, 320 million people covered by this that are implementing these policies now. We are launching next year a flagship regional framework on active and healthy aging. And we have launched a global commission on social connection, which is about bringing forward the best evidence-based solutions to reduce inequities. Finally, you started by asking us, where does the money come from? We've made the investment decisions here, but still, where does the money come from? We will be launching in the next 18 months an Impact Investment Alliance for Active and Healthy Aging. There is $1.2 trillion available of public and private investment to support transitions to healthier societies and healthy aging, and we'll be launching that, we hope, with the support of the G7 countries. So thank you.
Thank you. Thank you, Chris, for stressing the feasibility of these interventions, and thank you for the practical examples you gave us on how we can improve all of this. Dr. Basile, can you please tell us about the perspective of the Ministry of Economics, Italian Ministry of Economics, on the type of evidence needed to identify the best prevention strategies for elderly to invest on?
Yes. Let me start by saying that at the Ministry, we regularly carry out the analysis on important factors that affect well-being. This analysis is called Equitable and Sustainable Well-being and is included in the planning documents. The aim is to assess the impact of budgetary policies not only on economic growth, but also on other dimensions such as health, social conditions, and inequalities in terms of differences of incomes and gender. In the field of health, we selected the indicator related to excess weight. Why? Because at the individual level, it is proved to be a strong association between excess of weight and the development of chronic disease or disability. So the excess of that is one of the leading causes of mortality and disability of older people. So in the light of this evidence, and also as it has been stressed in this event, the best strategies would start from childhood and is to promote a healthy lifestyle, balanced nutrition, and physical activity. As a second point, we also know that healthy life expectancy at 65 years, which signal the level of well-being and health care that a given society can provide to older people, is strongly associated with a high level of access and quality of health care. So in the light of this evidence, and as it is already embedded in Italy's National Resilience and Recovery Plan, the strategy should be twofold. First of all, it's important to redesign the local healthcare network to make services available in a widespread manner throughout the national territory, especially by increasing services provided in home care that are more targeted to older people with chronic pathologies. Second, the strategies should make the most of the possibilities offered by new technologies, namely telemedicine, home automation, and digitalization, in order to best support the patient with disabilities. Thanks.
Thank you very much, Dr. Basile. Now, I'm asking Dr. Izutsu to share with us your experience. How Japan has dealt with the issue of aging population, and which are the strategies you have already put onto the field to face this.
Thank you, Roberta, and thank you for asking such significant questions. And it's vitally important for the government to deal with the rapid increase in the healthcare expenditure. And then as a government officer of the Ministry of Health, we are facing a huge pressure from the Ministry of Finance to reduce the healthcare expenditure. Do you agree with that? Okay. And then in order to deal with the cost of the healthcare expenditure, Ministry of Health has launched the national program. It's called the Medical Expenditure Optimization Program since the 2008. The purpose of this program is not reduce the healthcare expenditure, but to provide appropriate medical care for the patient. There are mainly three measures. That is, firstly, forecasting healthcare expenditure with setting the target. Secondly, enhancing health promotion. And thirdly, providing healthcare service more efficiently. In order to implement this program, Japan has revised the act to make sure the local government and the national government can act on this program together. So local government must have to provide necessary measures, and the national government have to provide technical cooperation and advice and the subsidy as well. When it comes to the enhancing health promotion, health checkups and the subsequent individual consultation and the health guidance with aim to supporting behavioral change has been conducted by healthcare professionals. Tobacco control and vaccination is also included as well. As for the enhancing efficiency in provision of the medical care, we work on the enhancing generic drug use and reducing duplication of drugs and the polypharmacies. And in that context, the data plays a critical role to play. Digital data helps to visualize the status of generic drug use. So this enables us to send the letter to the patient directly. For example, the letter says, you can save 10,000 yen if you choose to pick the generic. So the message is very strong. So this could enhance the patient to choose more generic drug use. And then also, besides that, data visualization also reveals the variation of the provision of the healthcare service among the prefectures. The prefecture is the unit of the local government in Japan, and then there are 47 prefectures, so Tokyo is also one of the prefectures in Japan. And then let me tell you the one example. When looking to the cataract surgery, eye disease, there are huge difference among the 47 prefectures. So the data showed there is threefold difference in the implementation rate between the highest prefecture and then the lowest prefecture. And then this, in Japan, it's allowed to operate a cataract surgery with the hospitalization or day surgery. And of course, day surgery is more economical, so data will facilitate the healthcare provider to do the more day surgery. So this is the one example how we can enhance to optimize the medical care. So what I'd like to emphasize is there is no single bullet to optimize or to reduce or to control the healthcare expenditure, but the most effective way is to take the multiple approach to tackling the rapid increase in healthcare expenditure. And then let me make a small pitch before the closing. Japan promotes to establish the UHC Knowledge Hub in collaboration with the WHO and the World Bank to support especially low and middle income countries, including the knowledge sharing on UHC and then joint coordination between health and finance. So we really, the collaboration with the other country, Italy or G7, will be very appreciated. Thank you so much.
Thank you so much for sharing with us this overview of the strategies taken by Japan, but also for stressing again how cooperation is so important. And I'm happy that we're here in the G7 summit to stress this and to find common solutions for these issues. Now we've heard about national, international, supranational authorities. What about civil society? Dr. Boccadoro Meri, you're a journalist like me. So what can we do as civil society to address this issue?
Thank you for the question. Our nation is aging rapidly, destined to grow older. This is a fact. We can change the future, we can change this fact. We only have to work to change the sustainability of longevity. As the estimated speakers have said before, many factors contribute to this, including the recent pursuit to longevity by beauty industry and pharmaceutical companies. Aging should not be considered a problem, or worse, a detriment to society. Everyone has the right to age with dignity. But to do so, it's evident that the organizational system of all processes must be modified to adapt to the new increasing number of elder people and their new needs. The sustainability of longevity, the theme of the latest conference organized by the Silver Economy Forum this year in Rome, addresses this very issue. To ensure that aging in peace and dignity become a right for all, not just for the richest, government systems must quickly adapt to the significant demographic change. Now it's not the reality. Policymakers must immediately implement strategies to discuss the great divide between a declining birth rates and the aging population, a very big difference. To change the perspective and think of aging as a resource, it is crucial for civil society, especially in large cities where isolation is a significant issue, to intervene with local policy. I'm the president of Genoa Smart City, and I work now in this address. Let us not forget that one of the 7th goals of the United Nations 2030 Agenda for Sustainable Development, Goal 11, it is to make cities and human settlements inclusive, safe, and sustainable. This goal underscores the need to protect the most vulnerable groups and to build up the role of the elderly, particularly in urban areas. The protection of individuals at every stage of life is the foundation of the entire agenda. We have to leave no one behind. Therefore, safety in cities, age-friendly urban planning, inclusivity and social housing, intergenerational exchange, transmission of value, and bridging the digital divide are the pillars of a new policy. In particular, the social and care system needs to be revised, as well as the house system, with improvement in facilities and the introduction of smart apartments. From Genoa, these initiatives have been launched. The role of the elderly rights guarantor of the municipality of Genoa, the role of the healthy city manager of the municipality of Genoa, and now in Liguria, where the two most long-lived cities are here, Genova and Savona, we launched the project Liguria Network of Longevity Cities. This one carried out with public administration and the large national association Confcommercio, aimed to identify models to be exported to other Italian municipalities. Thank you for the attention. Thank you.
Thank you very much. I like your switch from aging to longevity. We should try to stress this, to stress that we can age in a healthy and active way. Thank you very much to all our brilliant speakers. I think we had a good overview of very practical, I must say, and feasible, as I said before, solution proposals. So I think we now have a good roadmap to proceed to improve our healthy longevity, as was said. Thank you very much. I leave the floor to Luana Ravegnini for the next panel.
Thank you, Roberta. Thank you, everyone. Good morning, everyone. And now we can go with the panel 4, that is dedicated to AI, digital health, and robotics. This panel will explore the transformative role of technology in healthcare, focusing on how artificial intelligence, digital health solutions, and robotics can contribute to health and active aging. The discussion will cover the latest advancements in this field, showcasing how technological innovation can enhance preventive care, improve patient outcomes, and support independent living for older adults. Experts will provide insight into practical application, ongoing research, and future prospects of integrating these technologies into healthcare systems to promote longevity and quality of life. And now I'd like to introduce my relator. I'd like to have here on the stage Dr. Alice Borghini. An applause, please. Please. Dr. Matteo Lafranchi. Professor Agnieszka Wajkowska. Dr. Antonia Ricci. And Professor Lorenzo Rosasco. Please take a seat. And now we start with the first relator, Alice Borghini, a medical doctor specialized in public health. She also holds a PhD in management innovation, sustainability and healthcare at Scuola Superiore Sant'Anna in Pisa. She's a manager at the Agency for Regional Health Services, where she coordinates the digital health and telemedicine unit within the framework of National Recovery and Resiliency Plan projects. Dr. Borghini, Italy is having a unique opportunity in terms of digitalization of the health system, thanks to the National Recovery and Resilience Plan. Do the investments also promote the use of artificial intelligence in healthcare? Maybe we need, thank you. Thank you, please.
Thank you. Good morning to everyone. And I'm very pleased to be here representing AGINAS, the National Agency for Healthcare Services, and that is also recently acquired the functionality of a digital health agency. So this is one of the our main topics in this time. Italy actually is facing major changes in terms of digitalization of healthcare service at national but also at regional level. And this digitalization process has been fueled by the Next Generation EU Fund that has been declined into the National Recovery and Resiliency Plan. This plan is a big plan of investment that is not focused on healthcare, but the one that is focused on healthcare is actually focused on the strengthening of primary care, but also on digitalization, innovation, and research in healthcare. Regarding the digitalization, Italy is, the financing dedicated to the digitalization is among 3 billion, so it's a big investment. And we are implementing several projects actually in the digitalization field. Today, I just want to give you some information about the 3 main projects that we at national and regional level are implementing. The first one is the, let's say, the improvement of our e-health record system. Italy has had implemented the first e-health record system in 2012, so it's a long journey since now. And, but now with this fund, we are transforming our e-health record systems from the document repository to a data repository. So we are trying to realize a digital ecosystem with health data in order to improve our care. But we will also use this data for research and policy. Then we are implementing another big project on telemedicine. This project on telemedicine is actually led by AGINAS, the agency who I work for. And this is a very big investment in terms of financing because it's 1.5 billion dedicated to telemedicine. This project is basically realized in 2 different phases. The first one, in the first phase, we had realized a national telemedicine platform. This is a governance platform. So this platform will provide services like monitoring, reporting, or, for example, standards in terms of technological standard, organizational standard of care using telemedicine. And then we are realizing some regional infrastructure in order to provide telemedicine services in a uniform and equitable way. Regarding the artificial intelligence, we have another small project in terms of financing, but it's still very important. That is a project based on artificial intelligence tools aimed to support the activity on the primary healthcare sector. So that's an overview about this project and artificial intelligence project.
Thank you so much, Dr. Borghini, thank you. And now we can continue with Dr. Matteo Lafranchi. He is the coordinator of the Rehab Technologies Lab at the Italian Institute of Technology here in Genoa. His main work focus is on the development of novel bionic systems and rehabilitation robotics. Along with the research, he is also involved in technology transfer activities to bring the developed technology to the medtech industry. Dr. Lafranchi, what is the Rehab Technologies Lab doing in the field of application of novel technologies, AI, robotics, and digital technologies into the rehabilitation field?
Thank you first of all for the invitation. It's a pleasure for us to be here. Well, what we do is to apply robotic technologies to, as you just said, right, for limb replacements, for example, so bionic prostheses, and also wearable devices such as exoskeletons that can help. These are basically devices that a person can wear on itself and to do either rehabilitation or therapy. In the first case, we're talking about bionic prostheses. They are, let's say, 100% assistive devices that people can use during their daily activities, right? And while instead, when we talk about exoskeletons, they can either be used as therapy, for example, for chronic patients, people who cannot, for example, regain, right, motor capabilities. And this has been proven. I mean, there are some scientific studies that prove that, there are many, many benefits, such as, improved muscle tone, improved bone density, blood flow, many, many different, overall, a better psychophysical state. And this is what we do on chronic patients. On incomplete people that can actually regain capabilities, motor capabilities, such as in stroke patients, stroke survivors, or incomplete spinal cord injury. In that case, it has been proven again that this type of exoskeletal technologies, if used intensively already in the acute phase, in some cases, they can actually restore the nervous pathway, both at the peripheral level, but also the central nervous system. So there are different types of contexts where these applications can be used. Our main strategy, and also another line of research that we just started on one of those, on one PNRR resilience, funds, is actually to also is in the smart home, basically, technology. So the idea is to install sensors within the house, so then you can do prediction and prevention, right? So especially for elderly care. And this is a project that we just started, but we mostly do, so far in this year, we've been involved into robotic technology. We work at very high, I would say pretty high TRL, so, we develop these devices up to, very next to what can be a product, so at the pre-industrial stage. And the reason for this is twofold. So on one case, we can use these as platforms also for clinical research, and it is needed to have a very high maturity of these technologies. That's why I'm talking about TRL, technology maturity, because then you can go onto patients, onto patients basically in a safe way, right? So you can develop technologies, they are robust, they are safe, and then you can put them either for in the hospital or at home. And most of our technologies, and by the way, There are a few of them on display here on the other room, and there's a large representation of our group here today. So they will be able to show also demo of these devices. And so getting to this high TRL and maturity allows to put the actual machines on the devices, enter the hospital, enter the homes, and do clinical research and research also on embodiment and user experience and so on. These all things are also very much related to technology transfer, which is the second point that we get by using the high TRL, high maturity of this technology. Because in robotics, it's not enough just to have the invention, to have the patent. You actually have to go to the application and show it actually works, right? To then be able to attract investors and capital funds to start a new business. So yeah, this is our way to do research. We work with very high TRL. Our machines are already, as I said, already entering the homes in some cases and hospitals, so they're already ready for deployment. And yeah, this is it.
Okay. Thank you, Dr. Lafranchi. And now we continue with Professor Agnieszka Wojkowska. Is the head of the Unit Social Cognition in Human-Robot Interaction and is the coordinator of the Center for Human Technologies at the IIT. Her team develops robot-assisted training protocols for children diagnosed with autism, combining cognitive neuroscience methods with the human-robot interaction. Professor Wojkowska, as coordinator of the Center for Human Technologies, can you give us an insight on how the application of robots in healthcare benefits from fundamental research, and what is your experience in the field of autism?
Thank you so much. Thank you for inviting me here. Maybe first I'll say a few words about, in general, why we're working with children with disabilities and how does this relate to active aging. So, yes, we develop robot-assisted training for children with developmental disabilities. And one has to keep in mind that these children will grow up one day, right? And as they grow up and as they enter adulthood, very often they have difficulties in entering adulthood in an autonomous, independent way. So it is very important to actually train with, what we do is cognitive training. So it's rehabilitation that is on the cognitive level, which is very different from physical rehabilitation. And one needs to start early in order to prepare those children to later on enter adulthood in an independent, autonomous way. So this is how this is related to active aging, because children of today will be adults and then aging adults of tomorrow. Now, children with developmental disabilities, there are 240 million approximately worldwide. We're talking about really large numbers here. And those children very often, as they age, are left later on without care and without the possibilities to indeed be independent adults. Now, how do we, so what do we do, first of all, with the children? We work with a humanoid robot that has been developed in our institute, the Italian Institute of Technology, the ICAB robot, that has a very human-like shape. And therefore, it can be treated as a sort of a social partner for the children. And what we do is that they interact with the robot in a game-like manner, where we develop training protocols within those games to train specific cognitive and social skills to engage later on with adults in a way that healthy, typically developing children would. So why robots? I want to stress here that we are developing robot-assisted training. The robots are there to assist therapists, not to replace therapists, of course. And the idea is also to offload therapists a little bit with, let's say, more repetitive activities with the children. Now, why robots? First of all, robots among children diagnosed with autism are extremely popular. Children with autism are very, very engaged and happy to interact with the robots. And why is that so? Well, there are various ideas, hypotheses why that might be the case. First and foremost, a robot provides a possibility to train and to play in a very repetitive manner. So we can actually program the robots to behave in an exactly same repetitive way over and over and over again. That allows children to train their skills in a way that eventually consolidate and they can use those skills later on. So one thing is repeatability of the behavior. Another aspect is that a robot is less intimidating than another human. It's not judging and is much more patient. So children do respond to those robots in a very positive way. And we have data showing that they indeed improve after several weeks in social skills that they actually transfer to interaction with other humans. So now I can get to your question that you asked, like how does fundamental research help? When we develop those training protocols, we target those training protocols for very specific cognitive brain mechanisms that we use in interacting with others. In order to know what to target, how should we design those training protocols, this is a result of our fundamental research that we perform in our lab in order to understand what actually is impaired and how you can design the game-like training in order to target that specific mechanism that might be impaired in children with developmental disabilities. So we transfer the knowledge that we gain from our lab into these application scenarios by understanding how to address the brain in action, in interaction with others.
Thank you. Thank you very much, Professor Wojkowska. Thank you. And now we'll continue with Dr. Ricci. Is the Director General of Istituto Zooprofilattico Sperimentale delle Venezie, one of the centers of the unique regional technical network centers for the protection of human and animal health within a One Health approach. Dr. Ricci, based on your institute experience, what are the applications of AI along the food chain to increase animal health and food safety? Can you give us an example? Thank you.
Thank you very much for the question and for the invitation. I'm very happy and proud to be here as a vet. I'm a veterinarian by education, so among health scientists, engineers, economists, and yes, I really believe that good ideas come at the edge. No, in between different professionals and competencies. So let's hope that this kind of event really promote this kind of exchange of ideas. Istituto Zooprofilattico, as you said, is a governmental veterinary institution. We deal in public health with the One Health approach. So what we do is to promote animal health and welfare and food safety along all the food chain with the final aim of safeguarding human health. And in my institute, well, we are a network of 10 different institutions in Italy. This is very peculiar of the Italian system. I also like to remind that in Italy, the veterinary services are within the Ministry of Health, really to stress the fact that veterinary health is strictly related to human health. In my institute, we are the reference laboratory for avian influenza at the European, national, and international level. And I wanted to give you an example of the application of artificial intelligence and new technologies to the control of avian influenza. So we are not dealing with chicken active aging, but avian influenza is really a devastating disease for poultry, first of all, We had an incredible epidemic a couple of years ago between 2021 and 2022 that led to the death or culling of nearly 15 million chickens, with nearly 300 euros of damages to Italian producers. So it's really a dramatic disease for the poultry sector. But avian influenza virus is now transmitting to, I would say, any animal species, so to mammals, to wild birds, to marine mammals. Is also hampering biodiversity at planetary level, and is possibly transmittable to humans. And in fact, avian influenza virus is the best candidate for a future pandemic. So dealing with the control of avian influenza is really controlling a potential dramatic disease for humans. The strategy for the control of this disease is early detection, because it's really an explosive disease. In 1 or 3 days, you can have the disease spreading in many different farms. So you really have to detect the disease as soon as possible. And unfortunately, animals don't say they are sick. And so you have to detect the first symptoms of this disease. So a very promising strategy is to put telecameras, sound detectors, sensors, is within the strategies of precision livestock farming. So to have the possibility to detect the first symptoms of the disease really as soon as possible in the farm through image analysis, sound analysis, because the vocalization of the animals can change at the first symptoms of the disease, even before the farmer realizes that the animals are sick. And also putting sensors in the farm so you can detect the presence of, for example, a different temperature or substances that the animals emit through their metabolism. And so through algorithms of artificial intelligence, it is possible really to detect the first signals of the disease, and through also some telemedicine application, really to diagnose the disease immediately, also avoiding that the vet enters in the farm, because this is also very dangerous, because of course people entering and going out from the farm and maybe going to different farms can diffuse the disease around the area. So this is a very promising application of artificial intelligence and new technologies to animal health, but really to human health. Thank you very much.
Thank you, Dr. Ricci. And now, Lorenzo Rosasco is professor at the University of Genoa. He collaborates with the Massachusetts Institute of Technology and the IIT. He is a founder and serves as a coordinator of the Machine Learning Genoa Center and the Laboratory for Computational and Statistical Learning, focusing on the theory, algorithms, and applications of machine learning. Professor Rosasco, the competence of future leaders, professionals, and AI is a major challenge. Based on your experience, what skills are needed for AI, and does the university training offer meet these requests?
So I guess it's a very rapidly evolving situation. So it's a hard to answer question, because what we know today might not be very useful tomorrow. As these things are right now, I think there is first of all, one thing which is clear is that AI, you should not think of it as necessarily a robot that is going to do stuff for us, but more like a telescope or another instrument that is used by a human to do stuff. Okay, so something that a doctor could use or an engineer could use. As such, there is a tremendous need for people to understand what AI is and to have what I would call basic alphabetization on, what does it mean to evolve an artificial intelligence. Now, the answer is somewhat divided because it depends who you are, you might need different skills. If you're in, say, you want to use AI or develop AI for decision support system in doing policy, or if you want to do health, or if you want to do rehab, you need different skills. But one thing which is clear is that the basic ingredients did not change. Basic math, programming, being able to run experiments, these are all the ingredients. So that's a good news because Italy has been always extremely good in creating basic fundamental knowledge in science. There is a novelty which is somewhat what one might call a paradigm shift. Historically, the burden is on humans to create models, but right now the burden is on data. It's all about data. So we try to get data to speak for themselves and give us indication of what we should do or how we can understand phenomena. And this creates a new way to mix those ingredients, those basic ingredients. And so the system as it is right now still is changing to reflect this new paradigm shift, but it's still based on somewhat old division, mathematics, informatics, physics. This doesn't work anymore. Sometimes I think I studied physics, I'm a professor in computer science, and I do applied math. And what would I study today? I don't know. It's a bit complicated. So there is an urgent need to go beyond the classical divisions and to somewhat create something new, and this is happening. An attempt to do this is to create new degrees, for example, the data science degree or the artificial intelligence degree. So I think this is the challenge that we face right now, and partially because the teachers has to learn together with the students. We have to create new teachers that can somewhat synthesize and integrate this new idea and teach students. And we don't necessarily yet have them. We have people, this came very quickly, right? It's something that came in the last 10 years. I think Italy, like most countries, apart from maybe China and the US, is chasing a technology that is changing really quickly. And so somehow we're trying to get teachers to become experts to then teach the new experts of the future. So I think that's a bit the state of affair right now. I think we can definitely count on the really good fundamental basis that we have. I think as a student, I wouldn't worry too much about what I do for my triennale, my third 3 years. Pick any of the scientific majors is going to be fine. But then I think there is an urgent need to somewhat synthesize new mixes of knowledge that are needed for AI, because right now we don't have them.
Thank you, Professor Rosasco. And we continue with the second round of questions, and I start again with Dr. Borghini. Would you detail the AI project proposed in the National Recovery and Resilience Plan, please? Thank you.
Yes, of course. I want to give you more information about this project. This project, I was saying before, is a very small in terms of financing if we compare to the other Recovery and Resiliency Plan project on digitalization, because it's around 50 million. But actually, we know that it would be very impactful on the primary care sector. This project as the aim to support the primary care sector and to support professionals who work in the primary care field, but also citizens and patients who use primary care services. In particular, we want to implement and realize through this AI infrastructure basically different use cases. Some of them are for professionals. For example, we want to support professionals with non-binding suggestion. So it's just a suggestion for diagnosis and treatment of the most common diseases that the general practitioner will reach through his work. And then we want to support also this professional in the defining the clinical personalized care pathway. We want also give them a suggestion and support in monitoring and remonitoring chronic patients that are the patients that more use primary care services. And we want also support and provide to the general practitioner personalized and dynamic patient profile in order to monitoring better all the patient. And another use case that we will implement through this project is to support professionals with in those activity, in those low value activity that are, for example, administrative and organizational activities. And then this project, I was saying before, want to will develop also 2 use cases for patients and citizens that are basically aimed to support all of us in, for example, education and information on preventive and prevention. And also want to provide guidance concerning availability, for example, of healthcare services. So it could be useful in order to reach the most appropriate healthcare service. Regarding the project, the implementation of this project, we are now in the phase of the tender procedure. This tender procedure will, at the end of the tender procedure, we will design and realize the digital AI infrastructure, and then we will piloting this project and this infrastructure for 1 year, and after this 1 year of experimentation, we will provide to this the tool to all professionals that work in primary care. That's actually a very, very challenging project, and in order to assure that the project will have more success, we are also defining within the tender procedure an education program for citizens and professionals, a change management program in order to foster this the change management that is beside the project, and also a communication and implementation strategy.
Okay, thank you so much, Dr. Borghini. And we continue with Dr. Lafranchi. What are the major difficulties you have had or foresee in the technology transfer process to medtech industry at national and international level of research related to bionic system and rehabilitation robotics?
Yeah, so regarding technology transfer, there are a few challenges, I have to say, that we commonly face when dealing with medtech transfer. And the first one, I would say, is all the regulatory practices that are needed, and the whole process that is needed to get, these devices to, compliant to standards, and so on. And this actually lately, with the new medical device regulation, which started in 2021, is getting even tougher. Okay, so what does that mean? You need basically large investments for having people which can actually take care of this, and we are actually pretty fortunate at IIT. We have large funding especially from INAIL, which is our workers' compensation system here in Italy, and which allows us to also, have a dedicated group of people doing this type of activities. And the same applies also to companies. So, for example, SMEs have really been impacted by this because, increased cost, increased time to market. So then, in the end, this is one of the main, this is one of the hindrances that we have there. We need actually large investments on both sides, on both research and companies to get these devices onto the market. The second point I would say is acceptance. This is actually very common in any sort of innovation, but especially here, whenever you innovate, you kind of disrupt the way things are done, and therefore you have to make sure that your technology is accepted and which can be easily used by the users. And for doing that, at least to mitigate this risk, what we do is to use a lot of user-centered design approaches, which are used to actually understand the actual needs, the actual clinical needs of the patients or the doctors, and translate that into technical solutions, right? So what we do is to tailor technology around the needs. And we keep them involved throughout the whole development process so that we are sure that then when we deploy, we are at least at a certain level of, certainty. We are sure that, the project, the device can be deployed with, not so many troubles. Also, now talking about acceptance and usability and ease of use of these devices, AI applied to robotics can really help. And so this is where we mostly use AI in our projects, and it is to basically, and this was also mentioned yesterday in the presentation by our scientific director, we use to detect the intention of the user, okay? We understand their intention by using biosensors that are placed around the body, and AI algorithms can get all this plenty of data and translate that into action. So, it basically it can be used as an interface between the human and the world. And so this is the second point. The third point is actually affordability. Of course, we always have, you have to be competitive. You can't just, invent new technology and put them at twice the market price for that category of or segment of device. You have to be in line, of course, with what is the price around. And this is not always easy. And this is because of two reasons. One, because, robotic technologies are intrinsically complicated. They have many high-precision mechanical parts. But for this, there is a turnaround, which I will explain in a bit. And the other main reason of the high cost is the regulatory process that I just said before. On this one, we can't really do much. We can instead work on the design. And just to give you a hint of what we do, we use some smart mechanics, and we have some examples out there in the demo area where we use under actuation. What does that mean? We use few numbers of motor to move many articulations, many joints of the body. Of course, I can't go into the details right now. It also would be a bit out of context, but there are ways around, right, to design these devices so that they are cost effective. One very last point is about the assessment of the technology, because very often when buyers are facing with the problem of buying or not a technology, it's always very hard to assess, right? And the very good news also is that right now there's this trend of having these health technology assessment procedures, which takes into account not only the clinical efficacy, but also the economic impact and the organizational impact. So then this will really much facilitate, I'm sure, it will facilitate the decision process of the buyer, and so therefore also facilitate the technological transfer.
Thank you. Thank you very much, Dr. Franchi. And we continue with Professor Wojkowska. What is your experience in the acceptance of robots in your specific use case in healthcare?
Thank you so much. So maybe first I should start with mentioning that we work in terms of application of those training protocols, robot-assisted training protocols for children with disabilities. We work with a local rehabilitation center here in Genova, in Boggiano Pico, which is part of the larger Don Orione Foundation. And the experience has been so far really, really great. I think it's a fantastic example of how things can work together. We can work with clinicians, with therapists, and with families to develop this kind of approach. So when you are asking about acceptance by users, I think I should perhaps categorize our users into 3 categories. So first, are the direct users, so to speak, so children. Regarding children, as I was mentioning already earlier, we have very, very positive experience, and the acceptance by children is extremely high. Children are super engaged. They really are happy and eager to come and play with the robot. They are often we hear from therapists that children that had difficulties previously and, so to speak, sitting through a therapy with a therapist, now suddenly, because we engage, we involve the training, the robot-assisted training within the sessions, the therapeutical sessions with the therapists, and now the kids with the robot, they're more willing to sit through the therapist and actually engage. We see in various ways increase of engagement of children, and we see this both in terms of scientific data, but also anecdotally. We hear often how children are just there mesmerized and happy, and they really eagerly, when they enter the center, they go to the room and want to immediately interact with the robot. So those are the children. Then the second category of users are the therapists. And here I must say again, thanks to our collaboration partners from Boggiano Pico, an incredibly positive experience of having therapists also extremely engaged and very also active in terms of proposing new ideas, proposing new ways of developing those training batteries. Because they know best. I mean, they know exactly what the needs are. And we have engaged in a dialogue where we actually co-design our training with the therapists. And I think this is a really wonderful experience where we need the experience that they have in order to develop our training protocols. So again, with the therapists, we have very, very positive experience in terms of acceptance. And finally, very, very important category of users are the parents and families. And also here, I must say that we have had very positive experience. We sometimes hear, again, anecdotally from therapists who tell us that parents report to them that kids come back home and speak about the robot, speak about their experience with the robot, which is something quite incredible for a child diagnosed with autism to share experiences, right? So this is something that we are really happy to hear. We see also children or parents bringing us drawings of the robot by children. So this kind of experience for the kids and for the entire environment, family and therapist is really, for us, very, very positive and incredible. Now, maybe what does one need to have this level of acceptance, and how can we get there actually to be accepted by the users? I think many of the points I'll repeat is for sure the sort of engagement of the users in sort of co-design. But what I wanted to say first and foremost is that, of course, this is not a process that happens immediately. One needs to build trust. One needs to develop a relationship. So in order to do that, one needs to have researchers on our side who are sensitive to the users, what the users say, who are able to listen and involve, indeed, the users in co-design. And then, finally, I think the thing that is very, very important is scientific results. So showing that this training actually really works. And this is something that we have been happy to actually publish, that our results do, our training does work, results are positive, and I think this is one of the most convincing factors for the users to actually use the technology.
Thank you, Professor Wajkowska. And we continue with Dr. Ricci. One of the major roles of your institution is to contribute to food chain safety. What digital solutions, including AI application, are being supported in surveillance system and management for foodborne infections?
So thank you very much for these questions. There are actually many applications that can be used to control foodborne diseases. First of all, just let me know a few words about what foodborne diseases are. Of course, these are diseases which are transmitted through the consumption of food due to the presence of bacteria or viruses or parasites that are present in our food. Of course, there are really plenty of controls along the whole food chain, from really the farming of animals to the table of consumers. And so these diseases have been really controlled in the last year very well. And particularly, I'm referring to very big events that were quite popular in the past. Let's think about weddings that are very dangerous from this point of view, that were dangerous, because really now all the controls in the food chain, in the catering systems, in the restaurants, have really reduced this kind of events. But now we see a different pattern that are more small events. Many of these really originate at home of people because really control system cannot arrive at the houses of people or small restaurants or people eating outside. And that's why it's really important to do a lot of health education to teach people how to treat food, how to prevent this kind of diseases. One question is that these kind of diseases remain in many cases undetected and unreported, because let's think that 20 of us yesterday were out at a restaurant and we got a foodborne disease. Now, foodborne disease do not happen immediately. Usually they have an incubation period of 2 or 3 days, so we all go home. Some of us can be sick at home, but probably we don't talk anymore to each other. We don't go to hospital because many of these diseases are not so serious to go to the hospital. Even if they are really fastidious, they produce a lot of losses of days of work, a lot of burden of disease for people, but fortunately, they are not so serious to go often to hospitals. And so they remain completely undetected. And under detection and under notification is a problem for prevention, because prevention is based on knowledge of what is happening in order to make the right solutions to prevent future outbreaks. So we have a project called Safeguard, financed by the Ministry of Health, which is using large language models. You know much better than me what I'm talking about, but all of us know about ChatGPT, which is one of these, to scan social media in order to identify possible foodborne diseases in people. Because maybe after this dinner yesterday, I'm not talking about the dinner yesterday, it's just an example. Maybe we go home, we don't go to the hospital, but we write on a social media that we are sick. these language models are able to do the so-called sentiment analysis, so really to understand what we are talking about, and of course to link also geographically the source of the disease, because on Facebook or whatever it is possible to understand that we all were in Genoa and now we are everywhere in other countries, but we can link also geographically this pattern. So is also this a promising project to help the study of this disease in order, yes, to prevent other cases and to understand these patterns better.
Thank you. Thank you, Dr. Ricci. And now the last question of this panel 4 is for Professor Rosasco. What are the research topics of AI, and in particular those you deal with at Machine Learning Genoa Center?
Thank you. So I guess one thing about the current state of the frontiers of AI to keep in mind is that right now the most successful players have been huge companies that can invest ginormous amount of money, and they have a very specific models, which is basically collecting as much data as possible and building the biggest possible computer to crunch them, and basically brute force solutions of problems this way. And this proved successful, for example, for understanding language, or not understanding is not right, so reproducing language. We still don't understand it, but we can have computers speaking really well. Now, the bad news is that I think, my opinion is that certainly university cannot replicate this model. I don't think most nations can replicate this model, because you really need a lot of money that I think cannot be put to just solve problems like this. And more than that, I think there are lots of problems that cannot be solved like that. And I think health, written everywhere here, is a good example. You cannot understand health through AI just by collecting data and brute force the solution. A, because we don't have enough data, and A, because it's insane. Why would you lose tens of years of knowledge, human knowledge, and expertise to rediscover what we already know before you can actually solve what we don't know? So I think that's the first venue of, I think, a very interesting direction for research, which is what is largely done, for example, here at the University of Genoa, but not only, which is come to terms with there is no progress if we don't interact with experts, okay? And so, for example, I think specifically in the health domain, there must be joint labs between technological engineers and computer scientists and doctors working together, because that's the only way to somewhat allow the AI to fully benefit what has been gathered through the years through knowledge in other fields. And I make the example of health, but of course, this goes on for many other fields. And so, for example, here, there have been a number of joint labs between the Ospedale San Martino, with the Gaslini, and more initiative coming. And each one somewhat has its own specialization. Some of that is clinical data, some of that are more about imaging, collaboration with Esaote, for example. Some of them are more focused on certain kind of diseases. And this shows that there is not going to be a magic wand that you just wave and then you can solve all the problems. So not only we have to work with experts, but with different experts for different fields. So I think that's one key observation to me, is this idea of working closely to experts and create these hybrid environments. I think the other observation is that there is a tendency to think that what we can do is just apply what's there, and that we only need to somewhat throw AI on data. But this is not gonna, we cannot just chase technologies. I think the other very important bit is to create our own technology. And the specific focus we've been taking from a methodological point of view is the observation that still big companies, they can allow themselves to basically have infinite amount of compute power. So you can, again, brute force the problem by running things like, the computers are similar to the one that used to be there in the 1960s. They're as big as a soccer field. But who owns them? So we cannot really do this. So there is an urgent need to make AI itself more sustainable. and more accessible. We need algorithms, solutions that can run on laptops, that can run on workstation, that are available in every office, and realize that we need new technologies that are a bit more, that make AI a bit more democratic, a bit more accessible and easy to use. And I think that's kind of what I've been, this sustainability of AI, try to develop AI which is more parsimonious, that use less compute, that use less data, has been one of the major efforts at the Machine Learning Genoa Center, where we try really to work on the foundational aspects of it. So we try to understand not only how to replicate intelligence without any worries of the expenses, how much it costs, but try to think a bit more how we can replicate intelligence like humans do. Humans can learn from very, very few data. We don't need internet to learn how to speak. We don't need internet to learn what's an apple. And so I think that's it's still there, it's always been there, and it's still a big challenge, and that's kind of the big challenge we try to face.
Thank you, Professor Rosasco. I'd like to thank everyone to be here, our relator, with the very interesting interventions. And I'd like to invite here on the stage Roberta Villa. Thank you to Roberta Villa.
Thank you, Luana. Thank you, Luana, of course. And thank you all the organizers, the Ministry of Health, Genoa municipalities, all the organizers and the speakers also from the other panels.
Absolutely. Thanks to this futuristic discussion with this panel, we come to the conclusion, like you know, and hope in many promising perspectives, we need to look to future with the ambitious goal of more and more active and healthy aging society. Thank you very much.
Thank you very much.
Thank
Sorry,
you.
I forgot the EET that had a big part in the organization.
Thank you.
Thank you, everybody.
Grazie. Arrivederci, complimenti. Salve.